Okay, well, thank you very much for being here, and I thank Drs. Long and Dr. Ford for asking me to be here. It's a pleasure. And I want to thank Marguerite, too, because so much of what she has just talked about are things that I have personally been encountering with the project that I have been working on really practically since graduation, which was a year ago. So what I want to do, and I've got about 20 minutes or a little bit longer than 20 minutes to spend here. Had I brought my entire presentation, it would have taken a lot longer, so I've narrowed it down. What I brought was my slide. This is the slide that the poster that I prepared for Sigma Theta Tau in Grapevine in October. And so my project, it's a project because it's not anything research. I wanted to really replicate the trial. It's called the RABBIT-2 trial. And my area of specialty is diabetes, but because RCTs are expensive and very laborious, and we didn't have the resources, so what we decided to do was to pilot this particular subject on a unit in my hospital at Covenant. And let me give you all a little bit of background. I know there are several people here that are very familiar with this because it's been on their particular unit. Just a raise of a hand again, how many people are not nurses? Okay, good. Well, I don't know how many of you have diabetes, but one thing I really try to impress upon people, especially people with any type of diabetes, type 1 or type 2, is that the treatment is going to replicate what the pancreas does. Pancreas is always secreting insulin around the clock, thank goodness, without us having to think anything about it. And when we eat a meal, then the pancreas gives us a burst of insulin to take care of that rise in glucose that we're going to see after that meal. And so when you put someone on therapy, especially insulin, you really want to try to mimic that same thing to get really better control when you have diabetes. And I had worked in an outpatient center for 10 years, and we had the autonomy to do much of this and saw that it worked. So what I wanted to do was to look at this a little bit further in school, because this topic was just beginning to really, over the last 5 years, has really begun to take shape in the hospital setting. We have new insulins on the market, and so what we know now about the newer insulins are that they really do, for the first time, physiologically mimic what a pancreas does. We have long-acting insulins and we have very rapid-acting insulins. And so what I found when I started doing my literature review was that what we know about hyperglycemia. Used to be when someone was admitted in the hospital with high blood sugar, usually that was not the primary reason they were in the hospital. Usually it's another reason. And so diabetes always took kind of second fiddle and was on the back burner, and no one really paid attention to blood sugars. But guess what? We know now the horrible outcomes that are occurring because blood sugars are allowing to be high. And so what we know is that we're at increased risk for infection of blood clots. Our length of stay is going to be longer. There's all kinds of things, outcomes, bad outcomes, negative outcomes that result from hyperglycemia. And so even presently today in med schools, med students are taught really the quickest, easiest, simplest way to fix high blood sugar is to give a patient what we call sliding scale insulin. So that means going and giving them a little bit of rapid-acting insulin prior to the meal based on what their current blood sugar reading is. There's no rhyme or reason for this. It's kind of a cookie-cutter approach. It doesn't matter if you're a very slender individual, tall, thin, or you're short and fluffy. You're going to get the same amount of insulin as the person next door, regardless of your weight. And so what we see in those cases are lots of problems with patients continuing to have high blood sugars, because once you give them a little bit of rapid-acting insulin, guess what? In 3 or 4 hours, it's gone. So you're having to repeat that same process over again. And so you can see how the length of stay would be increased. Not only do we see that, but we also see that potential for low blood sugar, because we may be giving someone too much insulin at the mealtime if we're giving that person the same amount of insulin that we've used to cover someone who is very fluffy. So what I wanted to look at was what's going on, and can we compare when you look at someone who does what we call basal bolus insulin, which is if you have a person on an insulin pump, we're trying to, again, create a situation where that person is getting insulin continuously, round the clock, and then they're giving a little bit of rapid-acting insulin based on the carbohydrate content that they eat, as well as what their current blood sugar level is. And so that is putting that person in the driver's seat. So what I wanted to do was compare if you had patients doing sliding scale versus basal bolus. Would you have improved control? Would you have, and there were 3 questions I wanted to answer. Would you have less hyperglycemia, less hypoglycemia, and would the length of stay be shorter? So what we wanted to do was create this pilot on a med-surg floor, and I found a physician champion who had already worked inside of a hospital who had implemented basal bolus and get rid of sliding scale altogether. Well, he's been fantastic. And so throughout all of this, we created, and again, I could not have done this had I not gone back and gotten a master's and learned more about research and had that fire lit under my feet or wherever. Because it's very easy in nursing to stay sort of stagnant and not do a whole lot. And so with this knowledge that I now had, there was no way ethically, morally, that I could continue on in practice knowing that there's a better way out there for patients and that we're not doing anything about it. So I found someone that felt the same way I did. We created a team of people and various nursing staff, and we decided that we would start this pilot, a 3-month-long pilot, from January through April the 23rd. So this coming Monday would be the 23rd. And I did all of the teaching to the bedside nurses, and of course you can imagine no one wants to change, you know, what about this, what about that? But when you explain the rationale, basal bolus versus sliding scale, and you're doing a correction bolus for a patient's blood sugar based on weight and not based on something that's already happened, we do reactive therapy. This is reactive medicine, not being proactive. Well, then they started to understand. And, oh yeah, well that makes good sense, So then the physician was going to do the training for the hospitalist. And the hospitalists are the doctors now in the hospital who are seeing you. If your primary care doctors probably are not coming to the hospital like they used to. So it's these hospitalists that are seeing you through your time in the hospital, and they're the ones managing your medical care. So I got very excited about this, did all the teaching, and we were ready to go. I created a document or created a tool on Excel, and so I was going to be following our pilot patients to see what we were doing. Now, what I had done, though, is I had looked at last year, and I had taken a sample of about 188 patients that I looked at, and actually had some help from another nurse, and looked at to see what was the average blood sugar on that floor, the same floor that we're doing the pilot on, for 3 months. And not knowing their therapy, just that they had diabetes, and that's all I had to look at, and I looked at blood sugars. I found the average blood glucose was 188 or 185. It tells you on your sheet there. actually it was 183 patients, and 188 milligrams per deciliter was their average. Okay, well, I want to back up because guidelines, our current clinical guidelines from the American Diabetes Association, as well as the American Association of Endocrinology, tell us that basal bolus is far superior in a hospital setting over sliding scale insulin. So we have those guidelines. It's nothing that's made up. The guidelines are there. We're just not utilizing the standards of care. So what I wanted to do was to compare to see then the patients that we looked at 3 months later using basal bolus. How did that compare? Could we get our average down? And so that's what basically I was going to look at. Well, I got very excited. For the first 4 weeks, we had a total of 7 patients. And then I started to see where we were having less and less and then none. So that discouraged me. But I, along the way, have also met, there's a new hospitalist who has a great deal of research experience and had worked at Texas Tech with one of the endocrinologists there at the internal medicine clinic. And so she's going to lend me a hand also. What we're going to do is revamp. It's not been nursing per se, it's been physician barriers. And so I'm learning this from my physician champion and his theory on what's been going on. We have physicians that don't want to change. I mean, they're no different than anyone else. And so this is going to be a culture change. I knew it wasn't going to be easy. Nothing is. I know it's a journey, and I'm willing to ride that journey. But through this, it's also teaching nursing personnel at the bedside that there is a better way, and to get them to start thinking about, why we do things the way we've done it all of these years, and that there are better ways, and to be thinking about, what other ways are out there. So just that encouragement. And one thing that I learned not long ago that I guess it's originating from St. Joe's, our mother hospital in California, is that we are looking at these clinical effectiveness initiatives. And that's all very new to me, but that is so exciting because what I understand about that is that we've got a consultant who is helping with these initiatives, and it's affecting right now there are like 9 or 10 disease processes or surgeries, and so they're taking evidence. They're looking at what's out there, and they're getting physicians on board, nursing staff, and so they're being able to critically appraise what the literature says and then go with these new bundles of care. So that is so exciting. I'm just so excited to hear that. We're going to maybe come through a different route and incorporate evidence-based medicine. So I just encourage all of you out there in the master's program, those of you all who are working on your bachelor's, and if you go on and work on your master's, fear is our worst enemy, and we are our worst enemy many times by not allowing ourselves to move past fear of failure. I sometimes walk up to the units, and I know I'm looked at as, someone who is trying to rock the boat, but, I'm a leader, and I am an agent of change, and I think that's the way we all need to look at ourselves as nurses. And I'm not going to give up. I'm going to fight right along, and I don't see it as a fight. It's just, again, the doctors have been so ingrained in doing this for so long, and it is very easy and it's very simple to do, to write a short little, or look at a protocol that's very simple and say, give this amount of insulin, and they don't have to be bothered. But, we'll just continue to work through the rocky areas and And it may not be in my lifetime. It may be a little bit longer. I don't know. But I do think we're going to see things change. This has started to, other hospitals are starting to move towards what we call standardized order sets, and they are incorporating basal bolus, and they are not using the traditional sliding scale insulin as we know it today. So, you know, if you're my relative, I want the best care for you. If you're my friend, you're my child, you're whatever, I want the best outcome. And so I'm excited that at least we've got some open people in our organization that are helping move this forward. And that's really all I have. I mean, if you can read the information on the slide there. I would like, after we eventually, if we can get rid of sliding scale and move towards basal bolus, there's going to be lots of other questions that come out. You know, how do nurses feel? How do physicians feel? But I don't see it as creating any more work. Are there any questions? No questions?
I'll ask you a question.
Okay.
Thinking about what you've said, you're actually trying to incorporate this change into practice based on evidence, and then Dr. Fallon. Can you tell me, and maybe Marguerite, if she's still here, could help you, how does the conversation around the water cooler change when nurses who are in practice are challenged to ask questions and to move evidence-based practice to the bedside? How does it change from the past when they're challenged to step up and actually incorporate these changes?
That's a good question, and I think we're just now starting to see this, Dr. Long. For example, I chair nursing policy procedure, and one change right now that's going around lately is the policy or the protocol on NG placement, nasogastric placement of feeding tubes, for those of you all that aren't in medicine. And currently we listen with a stethoscope to see if we're in the correct placement over the patient's stomach. And so we're learning that that is not evidence-based, that there are a couple of other things out there that are recommended. And so our hospital is now looking at incorporating something where you would actually use pH paper, and you get some gastric contents and put on that, and so you know where you're at for sure. And it's much less costly than doing an X-ray. And so that will change practice, I'm sure. And so right now we're not really sure how to go about doing that. Do we create? One of the groups is looking at creating a pilot on a couple of ICU units and looking at the pH and paper and such as that for 3 months. And then someone else came along and said, well, why not? Why are we reinventing the wheel? Why don't we see what St. Joseph's is already using and go with it? Well, you have to look at where you're at too. California is very different. They are a lot more open, a lot more liberal, and we're just so different culture here. So I think it's going to be tougher, and I think there's just probably more challenge here. I don't know. But things like that, and so I think this is one of the first policies we're seeing that's really looking at changing policy. It's been this way forever and ever and ever, and now a change. So we'll see. But it is exciting to know that we can go, where we can go and find the literature, what the literature says, and look and see what the evidence is. And so I don't know if I really answered your question, but we're just learning. We're just sort of taking these baby steps, and that's the hardest part, is implementing evidence-based practice into your policies and, and procedures. And it's so that's what's so exciting about having master's students, because we can talk the language. And, you know, when you're talking to someone who hasn't had that preparation, they really have a hard time relating to what you're talking about. So I think that's what's so cool and so neat, is to see all the influx of nurses that are going back for their graduate degrees and learning and talking that lingo. And I mean, that's exciting for me. It may not be for some of y'all, but it is for me. So, yes.
Elaine, I know you have your 3 questions here, and you're revamping your study, but based on your reading of the literature and the studies that you've seen already, could you speculate on what you expect you're going to see with the implementation of the basal bolus?
I would expect to see less hyperglycemia. I would expect to see your average numbers, instead of 180s, come on down to closer to 140s. That's the clinical guideline. That's what I would expect to see. I don't know if I could really expect to see a decreased length of stay. Our length of stays currently are so short right now, and so it's hard to know if it would be because of that. But I think we would see less hypoglycemia. And that's something else I learned through all of this, is that our hospital does not track hypoglycemia. And I'm not sure other places how much tracking they do either, but it certainly needs to be tracked. Hypoglycemia is severe low blood sugar, enough to have to be, you know, emergently resuscitated from that. And so I would expect to see less low blood sugar and less hyperglycemia, for sure. Just the few patients, the 7 patients I looked at, didn't see any hypoglycemia. Now, you know, but I didn't see any, and so that was exciting, just in those 7 that I saw. So, and that's really because the amount of insulin given when a blood sugar is elevated is really based on that person's body weight. See? And so now you've got something to base it off of, and their total daily dose of insulin. So that makes a lot more sense. Okay? Anything else? Okay. Well, I'm excited about your posters, and I will try to get over and look at least my nurse friends back there that I know are over here. Thank you.